Good afternoon, good evening. Thank you so much for joining us for the weekly briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I will be moderating this session. The weekly briefing touches on health emergencies across the continent. And today we are joined by Dr. Ngashi Ngongo, the head of the Incident Management Support Team based out of DRC. Dr. Ngashi is also the principal advisor to the Director General of Africa CDC. I will now hand over the floor to Dr. Ngashi to start the session. Over to you, Dr. Ngashi.
Thank you very much, Director. Good morning, good afternoon, good night, colleagues, depending on which part of the world you may find yourself right now. We are pleased to bring again to you this weekly update on the situation of public health emergencies on the African continent. Apologies from the Director General, who really wanted to be with us once again, but he found himself involved in other commitments. I think most important before we start, just to say that with the Ebola as the new emergencies, also a new emergency that was declared on September 4th, we are in the context of multiple outbreaks on the continent, also creating competing priorities in the context of limited resources. Huge challenge, but great effort also from the government themselves and all the partners working together to control the outbreak regardless of the difficult circumstances. It is with that background that, Director, I would like to take them through the PowerPoint presentation, if you can get it on the screen. Thank you. Let's move on to the second slide. Yeah, just to say that last week on Thursday, 4th September, the Minister of Health declared the outbreak of Ebola as a national emergency in the DRC. Very important, the Director General made a trip to the DRC and met with the Minister to also discuss how we can align the immediate response with the support of different partners that are gathered around the Continental Incident Management Support Team that is co-led by Africa CDC and WHO. And at that opportunity, there was a meeting that was organized under the leadership of the Minister of Health with all the partners present here in the DRC just to discuss how we can coordinate different interventions in support of efforts to control the outbreak. I think there was some consensus on the key measures to control the outbreak and also how to work together for the rapid containment. Next. In addition to that, 2 days ago, there was also a very important meeting that took place in Abidjan to discuss the Lassa fever vaccine readiness in Africa. That meeting was organized under the leadership of the West African Health Organization in partnership with Sept and IVI. It was attended by West African ministers that all pledged their commitment to really support effort for the development of a Lassa fever vaccine on the continent for the continent. And the Africa CDC strongly supported this initiative, not only participating, but also because this initiative aligns very well with the continental agenda of Africa CDC on African manufacturing and the health sovereignty. I think Africa CDC will continue to be engaged to support its end-to-end support of the local manufacturing from the research and development up to the demand creation to ensure that the production in Africa can really get the market that it needs for it to be sustained over time. Next. Important also to say that on the 2nd of September, there was a meeting of the Emergency Consultative Group of Africa CDC, which recommend to the Director General whether to declare or lift up the public health emergency of continental security. The group unanimously recommended to maintain Mpox as a public health emergency of continental security, while recognizing that there were significant progress that were made over the last quarter compared to the last time. I think for the first time, we have seen many of the curves that are bending across the continent, but it's too early with the early progress of 3 months to then declare victory. The decision was based on a number of points. First is the fact that we still have about 5 countries that have shown the continuous stages of cases in the last 3 months. We've also seen about 6 countries that have shown new introductions of Mpox in places where Mpox was not reported before. In addition to that, the response itself, despite the great progress, I think there are still many gaps that are identified in the area of surveillance, in testing coverage, in access to vaccine. I think for which the Continental Emergency Consultative Group felt that lifting at this stage really incurs the risk of losing the momentum and also the resources that are being invested with the higher turnaround, which could be the increase of cases in countries that have already managed to control. The ECG calls for really strengthening the current response in the area of surveillance system that they really called for strengthening, in particular, the community-based surveillance. Also called for good investigation of the factors that are contributing to high mortality in some countries to understand how to tailor the response. They also called for a good understanding of challenges that are related to access to vaccines and how we can really improve on that. And finally, they called for the really sustaining the strong continental coordination, which has been one of the great success of this response. Now, coming back to the public health events, just to say that from AP week 1 to AP week 36, we have seen, I think, the 5 top outbreaks remain. I think that's Mpox, which affects 26 member states with 108,796 suspected cases and 776 deaths that have been reported. Then it is followed by cholera, 23 countries, over 238 cases, and over 5,000 deaths that have been reported. Measles affecting 19 countries, dengue affecting 10 countries, Lassa fever affecting 4 countries so far. But when you look at the pattern on the moderate and the high-risk events, when we compare 2024 with the first 36 weeks of AP weeks of 2025, we have 166 moderate and high-risk events reported compared to 119 last year. We can see from there that we are for sure going to exceed the total number of events in 2024. The similar trend is also seen when you look at high-risk events. We have already reached 49 compared to 72 for the whole of last year on moderate events. Same trend, 117 compared to 147 in 2024. Now, starting with the most recent, which is the Ebola virus disease in the DRC, the declaration went out on September 4th, but as of 8th of September, we have 68 suspected cases that have been reported, 20 that have been confirmed, and 16 deaths so far. That gives us a case fatality rate around 24%, and about 2 districts called health zones in the DRC that have been affected with confirmed cases. But when it comes to suspected cases, about 4. We are still waiting for the lab result, but 2 have already reported confirmed cases out of the 519 district or health zones, as they are called here in the DRC. Now, when we look at the breakdown, suspected cases, the week 27, there have been 11, I think, that have been reported compared to 46 in week 36. The number of confirmed cases, 15. I think these are cumulative numbers because of the time it really takes to take the samples in the remote places where this is happening to the laboratory test and then get the result ready. And cumulative deaths since the beginning is 16, with a case fatality rate around 24%. There to say that currently there are about 9 cases, I think, that are under care, of which 4 in critical conditions. Again, as a reminder, that the index case is a 34-year pregnant woman who went into labor on 20th of August and then died 5 days later. She presented with symptoms of fever, bloody diarrhea and vomiting, nasal bleeding, and anemia. But also the laboratory technician who collected the samples has died together with the attending nurse. But in terms of demographics, I think so far males make almost 54% of cases, and the most affected age group is the 15 to the 64. That to say that the contact listing and follow-up is also doing relatively well. 401 contacts that have been identified, 398 that are being followed, which represents 99%. But the contact ratio of 1 to 6, which is still of great concern, the response is just kicking in now. I think the effort is to move that to reach something around 1 to 20. Very important also to report that sequencing has been done for the positive cases. And the main observation is that the current strain is closer to the 1976 outbreak, meaning that this seems to be a new zoonotic spillover event, which is not really close to the most recent outbreaks in 2007 or 2008, 2009. But what we have now is that 6 samples have been tested at the ENRB using GenExpert Ebola assay and also the real-time PCR. 5 samples turned out to be positive for the Ebola Zaire. And these are the ones that went then through the sequencing that has confirmed that it is a new introduction. Now, looking at the geographical distribution, you can see that these cases are in the Kasai province, really towards the center of the DRC, close to the Sankuru province, close to the Kasai province, but some distance from the Angola border. But there to say that in total, we have the 68 cases, but mainly concentrated in Bulape health zone or district for other countries, which account for almost 90% of all the cases. The case fatality rate, 25%. The second affected health zone is Mweka with 4 cases. Also, the case fatality around 25%. And then there are 2 other districts, Mushenge, that account for 2, and then the case, which is the new one, 1 case, but these are just suspected, not yet confirmed. They are to say that this is the 16th Ebola outbreak reported in the DRC, but the 7th in that specific region in Kasai. But the good news is that the country had a stockpile of about 2,000 Ebola vaccine doses, and vaccination has already started. I think about 68 frontline workers have already been vaccinated. In addition to that, the country is also keeping 100 treatment of MAB 114. I think that have also been deployed with Africa CDC support to the affected district. Now, coming to Mpox, overall, I think the picture, when you look at the epi curve, you notice that globally across Africa, by epi week 35, we have maintained a declining trend. But it is important to say that when you look at the cases in epi week 35, both the suspected cases and the confirmed cases, we see a weekly upsurge, and also, but the number of deaths is more on the decline. And it is important also to look at the comparison between 2024 and where we stand right now in terms of the number of cases suspected and confirmed and deaths, that by week 35, in 2025, we have already reached 135% of all the cases reported in 2024, and 166% of cases reported in 2024, and 469% of deaths reported the same year. That means that the burden this year is much higher than what we had in 2024. But across the board, when we compare with the peak week around week 17, we have noticed a 67% decline in weekly confirmed cases. And also, when we look at the 6-week average of confirmed cases, we see also a sharp decline, about 54%, from about 1,441 cases per week during week 17 to week 22 to about 640 cases per week during week 30 to week 35. I think this is what we also reported to the ECG, that across the board, I think we see now for the first time a declining trend across the continent, which is very encouraging. Now, I think our effort is to make sure that we maintain this over the coming 3 months to be able to move the continent also to the situation of control. The similar good news also on the testing coverage, we have seen an increase across the continent from 30% to about 64% over the last 6 weeks. I think these are the kind of improvements that we really want to sustain to give the continent a chance to bring this outbreak to complete control. Now, when we look at the performance of different countries, I think we have a number of countries that have shown an upsurge in confirmed cases when we compare epi week 24 to 29, and then the 6 weeks of epi week 30 to 35. I think those include Mozambique, that has got the highest upsurge, but just to say that when you look at the numbers in the table on the left, these are small numbers really that have moved from 9 during the week 24 to 29 to 60 in week 30 to week 35. But there are countries where we've seen an upsurge with high numbers. These are Guinea, 99% increase, Kenya, 70% increase, Ghana, 69% increase, and Liberia, 48% increase. But we've also observed again increases in Tanzania, about 23%, Nigeria, about 19%, but those are also small numbers that we are talking about. Next. Now, coming to the DRC in particular, we see the sustained drop in the number of confirmed cases and also in the 4-week moving average. I think that has been maintained on the decline, which is really good news. That's a trajectory that we like to see also maintained. But when you look at the number of cases in AP week 35, new suspected cases went up by just 3%, and the new confirmed cases went down instead by about 19%. Great concern it is the testing coverage, which is maintained around 27%, while the testing rate has gone up, reached 100%, and the test positivity also went down again to about 30%, which signals some improvement in disease surveillance. And just to say that when you look at the number of confirmed cases over time, comparing the weeks, the week AP week 52 of 2024, we had about 545 cases to the 6 weeks of AP week 30 to 35 in 2025. We had about 234, showing a 50% decline in the number of cases. But very important also to see the shift in the high burden provinces, which are now Sankuru, Bazwele, Tanganyika, and Sud Kivu. And currently, I think there are about 12 provinces that have been identified as hotspot out of the 26 provinces in the DRC. In Sierra Leone, we see a similar trend. Again, the decline that is maintained. But when you look at the performance in AP week 35, suspected cases and new confirmed cases have both gone down by 7% and 4%, just to say that Sierra Leone has really maintained that the decline. The good news is that this is happening in the context of very good testing coverage of 100%, meaning that all the cases that have been validated as meeting the case definition are tested 100%, and also all the samples that reach the laboratory are also tested. I think that's what we have, also 100% on testing coverage, 100% on testing rate. The test positivity rate is now at 52%, which is also very good news. As you see that the cumulative is at 77%, you remember that at some point, Sierra Leone had test positivity rate above 90%. That showed that they have really moved from passive surveillance and then shifting toward active surveillance. But on average, the weekly confirmed cases have declined by about 88%. That is from 508 cases during the peak week 17 to week 22 to about 62 cases in week 30 to week 35. And also important to say that now all the cases are concentrated in the western area, urban, which has got 55% of all cases, in the western area, rural, 20%, meaning that the two of them account for 3/4 of all the cases that are reported in Sierra Leone. And also the good news also is that there are now about 25 Mpox treatment centers that have been established across the country. In Uganda, we have seen an upsurge over the last 2 weeks. And when we compare the performance in AP week 35, we see that trend being maintained. The number of suspected cases and the number of confirmed cases have both gone up by 33% and 161%. But the good news is that the number of deaths remains at 0 from week 34 to week 35. And also some of the main highlight is that we still have challenges really getting data on testing coverage, but the testing rate is good, 100%, and the test positivity is around 42%. But overall, when you look at the number of confirmed cases, they have dropped from a peak weekly average of 278, that's in AP week 9 to 14, to about 67 cases in the last 6 weeks, showing a decrease of about 76%. Now, cumulatively, Uganda has reported 48 deaths among confirmed cases, but important to say that nearly half of those cases happened in the context of co-infection with HIV. And in the past 21 days, 27% of the district have reported new cases. In Liberia, it's a different trajectory. We see an upsurge also over the last few weeks. When you look at the situation in AP week 35, the number of suspected cases and the number of confirmed cases are both increased by 178% and 142%. But the number of deaths also remains at 0. And some of the main highlights: good performance on testing coverage, 100%, testing rate at 100% as well. But great challenges in test positivity, very high at 81%, although it is a decline from 93%, which shows that the surveillance is still more on the passive surveillance. I think this is an area that need to be really strengthened further. And when you look at also the comparison from week 21 of the year 2025 onward, we see that upsurge trend, which shows that really the numbers are still going up. And when you look at the confirmed cases, I think they average 52 per week during weeks 30 to 35, marking then the peak period in this epicave. Very important to also mention that 2 out of 3 cases, confirmed cases, are reported from MODERATOR, and that 100 out of 147 cases are being managed through home isolation, which means it is still predominantly home care in Liberia. In Guinea, the situation is also very interesting, and upsurge also observed over the last 6 weeks. If we compare the performance in AP week 35, no suspected cases went up by 103%, but the new confirmed cases went down by about 16% with 0 deaths. On the main highlight, good performance on the lab, testing coverage at 100%, testing rate at 100%, but test positivity rate at 19%, which indicates that really they are also pushing hard on active surveillance, which is good news. But then just to say that we look at the confirmed cases, we see that they peaked between AP week 30 to AP week 35 with an average of 89 cases per week. This outbreak appears to be increasing and is currently concentrated in about 6 regions, which include Conakry, Kindia, Farana, Kankan, Bokeh, and Mamu. And the situation in Kenya also shows an upsurge over the last 6 weeks as well. And when you look at the performance in AP week 35, we see that new cases increased by 53%, but confirmed cases went down by about 3% with 0 deaths. Now, on the testing performance, we see testing coverage is about 77%. That is a decline that we observed there, but the testing rate is good, meaning all samples getting into the laboratory are being tested. The test positivity stands at 33%. And when we look at the overall performance, I think we see a sustained rise from week 14, which is moving much faster after week 24, with the highest observed at weeks 33 and week 34, showing that the outbreak is still expanding. I think there's no plateau yet that is observed, that really we can consider it is still on the upward trend. We can also say that the peak period was observed in AP weeks 30 to 35, with an average of 29 cases. But the vast majority of cases, that's about 70% of all cases, are found in 3 counties, which are Mombasa, Busia, and Nairobi. But just also to say that from the surveillance data, about 4% of contacts have tested positive for Mpox. Now, on the vaccination, I think we have now about 3.1 million doses of Mpox vaccines that have been delivered to 12 countries, about 1.6 of MVABN, and another 1.6 of LC16, but delivered to the DRC alone. 18 countries have already granted regulatory approval for MVA, and 2 countries have considered people below the age, children below the age of 12. But 11 countries have rolled out vaccination, and with Kenya, that started on September 3rd. But just to say that about 1.1 million doses have been administered to 1 million persons that have been vaccinated. Sierra Leone received its allocation for the 5th round, which includes 67,000 doses of MVABN that was received on Monday, 8 September this week. Now, turning the page to the cholera outbreak, the situation is still on the upward trend also, that between week of AP week 1 and AP week 35, we have now reached 245,000 cases, 430 that have been reported from 23 countries, with a case fatality rate around 2.1%. Just to say that this is in comparison with the total of the year 2024, which was at 254,075, clearly that we are already heading to surpass this number in 2025. And in 2024, 20 countries that were affected, now we have already reached 23 countries, and we haven't yet gotten to the end of the year. Now, when we look at the percentage of change in cholera confirmed cases and deaths, comparing the 6 weeks from 24 to week 29, and then to the week 30 to 35, we see that there are about 4 countries or 5 countries that have registered some increase in the numbers. Those are Chad, Congo, Republic of Congo, Burundi, Ethiopia, and Sudan. And we have another 5 countries that have shown the decline instead. They are to say that we have new outbreaks reported in Chad and Congo for the first time, I think, during this period. We have noticed the rise in Burundi is about 90%, in Ethiopia 6%, and Sudan almost 1%, as I just reported. But we see some stability in high-burden countries, with Sudan still, despite that stability, with just 1% increase, but we still remains the country with the highest number of cases that are reported. And the decline, as I said, quite considerable, 83% decline in Angola, 62% decline in South Sudan, 42% in Somalia, 18% in DRC, and 25% in Ivory Coast. Now, when we look at the situation in Chad, we are still on the upward trend, a cumulative number of 1,433 suspected cases, 92 deaths, with a case fatality of 6.2%. I think this is really of great concern, this high case fatality rate. But when you look at the performance on AP week 35, the number of cases is still going up. It went up by about 41%, but the case fatality went down. I think with 24 days compared to 29 the week before. And the disaggregation of the people that are affected, I think females make 70% of all cases. And also, I think the current hotspots in Chad are mainly in the Wadai region, where there are 6 health districts there that are affected there. And in the Sila region, is 1 health district that is affected. The current attack rate is estimated at 76.8 per 100,000 population. And the main drivers of the cholera outbreak in Chad, it's mainly the movement of people, of the refugees that are coming from Sudan, but also the overcrowding in IDP camp. Now, I think the breakdown also of the state shows the 5 states that are the most affected, which are Chokoyane, Hajer Hadid, Adre, Amiyuna, and Abdi. I think those are the 5 most affected states. Next. The situation in Congo also concerning when you look at just the upsurge in the last week, a very sharp increase in week 35, more than 580% increase from 26 cases the week before to about 177, and also high deaths, about 27 cases that are reported dead out of the 177 of that week. That represents, as you can see, close to 15% case fatality rate. Now, and the current hotspots include Mbamu Island, Mosaka, Gamboma, and Congo Ubangi. The main drivers are mainly the vulnerable population along the Congo River, and also worsened by the poor sanitation situation there. Next. In Sudan, we see a different trend, more toward declining trend, sustained also over the last 5 to 6 weeks. But when we compare the performance in week 35, we see the same picture, a decline about 77% from 1,578 cases the week before to 358. The same on the deaths as well, that have gone down from 41 the week before to about 7. In terms of the distribution of cases, 51% among females, with children below 10 years making about 15% of all cases. Now, the hotspots are mainly concentrated in Khartoum and Darfur, and some of the main drivers are the disruptions, due to conflict, and also the mass displacement into crowded camps. I think the water scarcity and the unsafe surface water that is being used in the context of limited sanitation. Now, just to say that on the case management, I think there are cholera treatment centers and oral rehydration points that have been established in IDP hubs to facilitate the phase triage and also the administration of ORS and IV fluid. ORS for the mild to moderate cases and IV fluid for the severe cases. But there are also great efforts that are ongoing in the area of WASH, surveillance, and risk communication and community engagement. I think there are trucks that are bringing chlorinated water with daily free residual chlorine checks, I think, to control the quality of the water that is being supplied to the communities. But that is happening also in the context of really the intensification of the risk communication and community engagement that is even adapted to the local languages to ensure that all the communities are reached in the language that they do understand better. Next. The situation in Ethiopia also showing the declining trend, which is very encouraging. And when we look at the performance in AP week 35, we see a sharp decline by about 90%, 26 cases reported in week 35 compared to 270 the week before, and also 0 case fatality. I think which is very encouraging. That's why you see Ethiopia has shown really case fatality below 1% as recommended by the World Health Organization. Now, the profiling of the persons that are affected, females make 47%, and children below 15 years make 26% of all the cases. The main hotspots are in Gambela and Amara regions, and some of the drivers are the refugee influx, but also the flooding that has led to the degrading of the quality of water and the conflict that is going on in Amara region. Next. Now, in summary, we can say that on the Ebola situation, we have the new outbreak in the Kasai province, which causes major threat really to the national health systems. We know the usual disruption that cholera outbreaks bring, but also an alert on really watching the spread to the neighboring countries, in particular Angola, which is the closest. Now, also concerns about the spread to other districts and other provinces. There were 2. I think now there are 2 where suspected cases have been also identified or reported while pending confirmation in laboratory, but calling for the strengthening of a point of entry surveillance. Now, as priority, the government and all the partners, we are working to intensify surveillance. I think the rapid responders have already been deployed with epidemiologists, also combined with community health workers for home surveillance. There's also the strengthening of the cross-border preparedness, especially on the south with Angola, and the scale-up of case management now that the country has MAP 114, and negotiations are also onward to identify other antiviral molecules that can also help, and the IPC measures are also being rolled out. On the Mpox situation, I think we see across the board the declining of cases in high burden countries, which is good news, but concerned about the upsurge in those countries and the new countries that have also reported cases. We are now operating in the context of the maintained public health emergency of continental security. Next week, there will be a meeting in Addis of all the partners and affected member states to just review the interaction review, to also draw lessons and make recommendations on how we can accelerate the response to get all the affected countries to the control. But also at the same time, we'll be also thinking about the roadmap to Mpox transition so that countries start also preparing how they can fully integrate further effort on Mpox within existing health systems. But the priorities remain to intensify the surveillance, in particular community health surveillance, especially in countries with a high positivity rate, to move more toward active surveillance, and also the vaccination in hotspots, and most importantly is the transition planning, which is going to start next week. On the cholera, we see the decline also in cholera cases over the last 6 weeks of about 33%, and we see that decline. But at the same time, the outbreaks remained widespread across the continent. We are concerned about sharp increases in Chad and the Congo Republic. But the good news is that we see there's still the high burden countries, despite we see the decline, which is good news. But at the same time, we also need to maintain the foot on the accelerator to lower further the cases in those countries. Some of the priority actions include really to sustain the case management, especially the WASH interventions, and also reinforce the cross-border coordination and continue to mobilize resources to sustain control effort in all those countries. I think with that, I'd like to thank everyone for your attention, and then back to you, Director, for the comment and discussions.
Thank you, Dr. Ngashi. Let's cross over to the floor. We have Kemo Cham from Mano Reporters. Kemo, you have the floor.
Hello, good day. Thank you. I just need some, clarification based on technicalities. What constitutes, given the current declining cases in countries with high burden, including Sierra Leone, I want to know, according to Africa CDC, what constitutes an active outbreak? Also, in that context, in Sierra Leone, would you say there is currently an active outbreak? Thank you.
Thank you very much. Let's take the next question before Dr. Ngashi comes in. We have Michael Guarisa from Health Times in Zimbabwe. Michael, you have the floor.
Okay, thanks, Director. Sorry I joined in a bit late, but I just want to find out, in light of the Ebola outbreak, do you think as Zimbabwe, we should be concerned, and what would be your advice to other neighboring countries that are probably at risk of, the spillover of the Ebola outbreak that just been reported in the DRC? Thank you.
Thank you. Back to you, Dr. Ngashi.
I think Michael's question, I didn't get it. Can you just clarify a little bit?
Yes, he's asking about the spillover of Ebola, possibly for Zimbabwe.
Okay. Yeah, thank you very much, Kemo and Michael, for those very important questions. I think the definition of an outbreak looks at the context. If it's a country that has never reported cases before, it's not an endemic country. An outbreak is the identification of one case. Confirmed, it is an outbreak. It needs to be dealt with. But for an endemic country, it's an upsurge of cases above the usual endemic limit. I think that is the difference of how we define an outbreak, which is contextual, whether there has been an endemic disease or it is the first time that the cases are being identified in that context. Now, for Michael, the risk of spillover to Zimbabwe, is really, we would say, moderate in the sense that Zimbabwe is far from the DRC. Zimbabwe has got no border with DRC immediately. And Zimbabwe has got no direct connection to the DRC. But we live in a globalized world that the risk is not zero, so to say, because people can still come to the affected area, then fly over to Zimbabwe and find themselves then also carrying the disease there. But when we look at the area that is affected right now, it is really very far deep in the center of DRC. It is one of the remote areas. Now, from there to Zimbabwe, I think the risk is still very far. Unless that disease gets out of the Kasai province where it is and gets into the cities that do have flight into Zimbabwe, now the risk of Ebola to Zimbabwe increases. Over to you, Director.
Let's take the next two questions. We have a question from Raji, a reporter from the Washington Post. The question is, what does the Africa CDC make of the WHO Director General's decision last week to lift the Mpox emergency declaration? The next question is from Ruggero, senior editor at Corriere della Sera, a media group in Italy. The question is, which countries in the rest of the world are cooperating with Africa CDC in your efforts to contain the outbreaks of Ebola and other infectious diseases? Has Italy played any role? Back to you, Dr. Ngashi.
Yes, thank you very much, Turaji, and the question about the role of Italy. First of all, that's a very important question, but it is also expected. What has happened, the lift of the global public health emergency and the maintenance of the continental public health emergency, it is something that can happen anytime. It will happen in the future. It is expected. I would say just look at the 2022-2023 outbreak, which happened in Europe. When it was lifted in May 2023, if you look at the epi curve, you see that the cases were still increasing in Africa while they had declined in Europe. And then the public health emergency of international concern was lifted. It was clear that while it was no more a global problem, it remained an African problem. It's exactly what we see right now, where WHO might judge that this is no more a global problem. 5 countries that have shown an upsurge of cases. You have 6 newly affected countries since the last review. You see that in Africa, it still remains a problem. I think that's the reason why the experts that advise Africa CDC, all of them agreed unanimously. I attended the emergency consultative group meeting. All of them unanimously advised Africa CDC to maintain the status of emergency until the situation gets under control in those countries. But what is interesting, though, is the fact that the same members, about 6 of them, are also members of the WHO International Health Regulation Emergency Advisory Group that also felt that it remains an African problem. It is no more a global problem. That is the reality. But then what are the implications? I think the most important is what are now the implications of really maintaining an African emergency, which is no more a global emergency, is the fact that even one of the main concerns of the emergency consultative group is that it is extremely important to maintain the support to Africa, the support in terms of vaccines, the support in terms of resources to help Africa get to the finish line. That happened, I think, with the lifting in 2023, there was almost no support coming to Africa at the time. But then the times have also changed because now you have a continental organ, a continental public health agency that has been given the mandate to declare public health emergencies of continental security that can then also look at the specific realities of Africa and then declare whether it is to necessitate to be maintained or to be lifted. I think the fact that those African experts see that for Africa, it still remains a major problem is a reflection that African priorities might not be global priorities all the time. I think that's exactly what we are making of it, that it is extremely important for all the partners that are engaged with Africa CDC, with WHO, in the continent, in the African response. That is also the most important thing, that if you read the WHO declaration, it also calls for really maintaining the intensified support to Africa to get African countries to the finish line, because the reality that it's no more a global issue, but it remains an important public health emergency. Now, on the support that we receive from Italy, I think we have a number of countries that are still supporting the incident management team here on Mpox. I'm not talking about support to the Mpox in particular. I don't think at this moment, since we launched the second plan, there has been much really from Italy. Not much. I think perhaps as the colleague is asking a question, now that we also want more countries and more partners to join hands to support this acceleration effort, it might be good that you also become our voice, with the Italian government, to also bring them on board. Just to talk to us. We are there. You can contact us anytime so we can organize how we can collaborate with Italy in our current efforts to help those countries most affected right now. Over to you.
Thank you. Let's cross back to the floor. We have Ray, a reporter from the Bloomberg. Ray, you have the floor.
Hi, sorry, I think I was muted. Yeah.
Yes.
Thank you for the presentation. Just a quick question. I just want to find out if the CDC is in talks to secure more vaccines for Ebola, and if you can probably say from who, and if how many, if there's a number that is there in terms of that we're trying to secure for the vaccines. And secondly, maybe if you can also just speak into the issue of the outbreak and the concern that you have of the latest Ebola outbreak spreading across regions. I saw your presentation mentioned particular concern towards Angola. Thank you very much.
Thank you, Ray. Let's take the next one before Dr. Ngashi comes in. We have Kumba from Gambia Times. Kumba, you have the floor.
Thank you, Madam Margaret, for having me. My question is, Africa CDC estimated the continent needs to 6.4 million Mpox vaccines doses, but has currently secured about 5 million so far. What concrete steps are taken to close this gap, and how will equitable distribution be ensured, especially for high-burden countries? Also, my next question is, fertility rates in countries like Kenya and Sierra Leone remain unusually high, particularly among people living with untreated HIV. How is Africa CDC working with governments to strengthen HIV care access alongside Mpox response? Thank you.
Thank you. Back to you, Dr. Ngashi.
Yes, thank you very much to both Ray and Kumba. Just to say that on the Ebola vaccine, we are working with the government, and we supported the government to make a request to the ICG, which is the global mechanism which is managing the stockpile of vaccines. The ICG, the government wrote already officially to submit the request, and the ICG immediately approved the release of the 2,000 doses that were already pre-positioned in the DRC. Those 2,000 have already been released, and the vaccination of the frontline workers has already started. Now, in the stockpile, we're told that they have about 500,000 doses. That means that really with the initial approval, it shows that the ICG is going to consider to give more doses to the DRC. Now, to the question about how many exactly, I think the DRC is just working on its vaccination plan. As soon as the vaccination plan is ready, I think we'll know exactly the numbers that are needed. And it is clear that with the spread, I think the numbers will be increasing because there are 3 categories that need to be vaccinated. It is the contact of the case, it is the frontline workers, and also the health workers that are working in the health facilities, because they are also exposed that somebody might come with symptoms that are linked to Ebola, and that they have to be already protected in addition to the IPC measures and the protective gears that they need to be wearing. Now, on Kumba's question, one is that first of all, the steps we are taking to mobilize the vaccines. We are part of the global supply management group, supply working group. Yeah. We are part of the Global Supply Working Group, which is made of the main organizations that are involved in vaccines. That's WHO, UNICEF, Gavi, all those are part of that group. I think that's the group that has worked together since the beginning to mobilize the vaccines from the key partners. And in addition to that, we've also had some bilateral agreement with some of the donors, like the US government, as you know, the donation that came from the US government, with the European Union through ERA, that also had an agreement with Africa CDC to donate the vaccines from the European countries to member states through Africa CDC. I think that is the mechanism that continues to work to be able to mobilize the remaining gap in vaccine. On the equitable distribution, you'll see that all the countries that have been affected, all of them, we have supported them to come up with their vaccination plan. And we have an independent body, which is called the Technical Review Committee, which is a global body, including all the experts from WHO, from Gavi, from UNICEF, all of them together that review the country plans and then guide them in terms of both the population to be vaccinated, but also the quantity of vaccines that they need. It is upon that technical review that they make recommendations to the incident management plan, management support team. Those are the recommendations that we do then submit to the supply working group to be able to allocate the vaccines according to the need of the countries. It's a very transparent process. It leaves no one behind. But if anything, the problem we have is not countries that applied and did not receive. It is more some of the countries that have received more than what they needed. Now we are thinking about how do we then manage that. I think that's where we are. And then on the point about what we are doing on HIV care, HIV is a real issue. As you see, be it in Sierra Leone or in Uganda, you see the common pattern. The people that die most, the people that are most affected when you talk about case fatality rate, which is high, are the people that are co-infected with HIV. But also, we deal with it not only at case management. We start first from the prevention. We have really a holistic, integrated response. Because of the sexual transmission of Mpox in those communities, what we have been encouraging all the countries, if you see that integration that you have heard the IMST talk about, is to ensure that we bring in the national HIV control programs to work together, with the National Public Health Institute, in managing the outbreak, but also ensuring that all the services for the prevention of Mpox among people living with HIV and also for the care of HIV among people that are affected with Mpox during the time that they are being treated is also taken care of. The only challenge we have right now, as you might know, it is the PEPFAR decision. I think that decision, as you know, it has reduced the availability of antiretrovirals in a number of countries. So that as much as you integrate, but if you don't have enough antiretrovirals to be able to administer at that moment, that becomes a weakness in the response. I think that's the reason why we are also doing very strong advocacy, with the member state to make sure that we can work together to ensure that there is no disruption in the supply of antiretrovirals because of the direct implication on people living with HIV, but also on the integrated care of people living with HIV that are also infected with Mpox. Over to you, Director.
Thank you very much. We have next Ope from Associated Press. Ope, you have the floor. Ope, if you can hear us.
Yeah, hello.
Hi.
Thank you very much, Margaret. My question is, considering that the rates of cases in Ebola cases in Congo has nearly tripled from when it was announced to today. How critical do you consider this outbreak?
Thank you very much. Let's take the next one. We have Emery from the BBC. Emery, you have the floor.
Thank you, Margaret. My question is concerning the Ebola. We've seen the increase of health zones from 2 to 4. Are these people who have been fleeing or just just normal? Because we heard that some people are not receptive to treatments. They are fleeing instead of going to the health zone. So I wanted to know if those are the people who are fleeing treatments, or if people are cooperating with the deployed health workers in Kasai. And my second question is to know what is specifically the contribution of Africa CDC to fight this Ebola outbreak? Thank you.
Thank you. Back to you, Dr. Ngashi.
Yeah, thank you very much, Director. First of all, on the risk to the country is high. That's how WHO rates it. The risk to the country is high because there is a risk of spread from that district, the affected district, to other districts. That's exactly what we've seen. We had 2, now we have 4. And there's also a risk of spreading from that province to other provinces. You saw the map, the proximity with the Sankuru province, the proximity with the Kasai province. No, that shows that that risk is very high for the country. The regional risk is moderate. It's really moderate because it's not. It's mainly for Angola, which is the closest country, but also moderate because there's a risk of people that are moving from that area to other countries as well. But the global risk is low. Now, on the question, Emery's question about the spread of the disease. If you look at the spread of disease, it's what is often expected at the beginning or before the confirmation takes place, and also the response kicks in. Because at the beginning, people are scared. They don't know what it is. At the beginning, the practices, even of burials, are unsafe practices of mourning and burial. That's what happened because they did not know that it was Ebola. When you see the way people were mourning, they were touching the body and so on. That's why the risk at that moment is very high because some are family members that come from other districts, they come from other provinces, they come for burial, they do practice all that, not knowing that this is a disease that is highly contagious and with a very high case fatality. But right now, as we are talking about, the teams have already deployed in the area, including the Africa CDC teams also that are already on the ground to push the risk communication and community engagement to make sure that people are informed that this is Ebola. In DRC, they know what Ebola does. They know the high case fatality of Ebola for everybody to be informed. And secondly, is also to kick in the preventive measures, starting with the safe and dignified burials to make sure that people don't tamper anymore with the corpses or any belonging of those corpses once the case has been either suspected or confirmed. But at the same time, we are also pushing the IPC measures, the infection prevention and control measures, disinfect the household, disinfect the places with the health facilities where these people have been attended to, also push the vaccination of all the contacts, vaccinate them within 4 days to make sure that they are all protected. And then for all those that are infected, then isolate them and treat them with the MAB 114 that is there. Now, if you look at that, you see that really there's a full deployment of proven interventions that will help on one side, prevent the spread of the disease, at the same time also reduce the case fatality rate. What Africa CDC has done so far, first of all, we are coordinating the national response with all the partners. That's why from here, where we are seated, the IMST, we are coordinating how we can work together, the complementarity between WHO, UNICEF, Africa CDC, so that we know of the different pillars of the response. How do we then bring together our resources to have a comprehensive and synergistic response? In particular, Africa CDC has got the team on the ground to support the coordination of the response and make sure that there's sound planning, locally, and good coordination of the contribution of all the key players. Number two, Africa CDC has deployed rapid responders with epidemiologists on the ground there to support the surveillance so that all the alerts that are coming are investigated on time, all the investigations are sample collected for testing, all the confirmed then the contacts are followed, listed, and followed for 21 days. In addition to that, we are also moving into the recruitment of community health workers to support both the risk communication, house-to-house risk communication, but also the strengthening of infection prevention control measures at home, and also the surveillance to make sure that those are the people that can identify people that are at risk of developing a disease or developing already symptoms that are close or that can meet the case definition of Ebola, get them into the system. Africa CDC is doing that. In addition to that, we have also worked with the ministry here to ensure that we do transport, we are also giving logistical support to get the treatment in the field. It's a very difficult place where they are. As I presented, it's Africa CDC that has organized the transportation of the MAB 114. And finally is the management of data. The data management system that is being used there, it is the one that Africa CDC and the IMST developed for Mpox that we have now adapted quickly to be used for the Ebola as well, because that is the best system for emergency management that connects surveillance with laboratory testing, with case management, and with vaccination. Because once the tool gives you the case, then the tool identifies the contacts that need to be vaccinated for ring vaccination, and it's the same tool that is used in the laboratory, in the case management, to also include in the result for the case management, to also include in the outcome of the management of that patient. That is also Africa CDC support, just to mention but a few. Over to you, Director.
Thank you. Now we have Mustafa, from a journalist from Benin. Mustafa, you have the floor. Mustafa,
bonjour, oui, bonjour, mon nom est Mustafa, je ne suis pas du Bénin, je suis du Sénégal, et puis je vis au Canada depuis bientôt 16 ans. Je vais vous parler pas français, anglais, mais je vais parler en français, je vais être beaucoup plus audible. Je remercie Dr Ngozi de son intervention et de sa présentation pertinente, mais moi j'ai quelques réserves, Dr Ngozi, parce que je suis bien la situation de la santé publique. Et je vous précise auparavant que je suis anthropologue de la médecine et j'ai beaucoup réfléchi ces 4 dernières années sur la gestion des épidémies avec une perspective de l'anthropologie médicale. Et quand je vous entends parler des enterrements, des risques, et là c'est intéressant, Dr Ngozi, mais je me pose des questions. Dans tout ce que vous venez de parler, je n'ai pas entendu un peu l'expertise de l'anthropologie médicale pour mieux accompagner les populations confrontées à ces défis de santé publique majeurs qui persistent dans ce continent. Je voudrais vraiment que le CDC Afrique prenne au sérieux l'anthropologie. Qu'est-ce que l'anthropologie peut apporter de plus pour mieux aider les populations, nos communautés, nos parents à maîtriser ces épidémies récurrentes qui ne vont pas s'arrêter d'un coup, mais qu'il faudrait essayer de contenir et d'être résilientes face à ces épidémies. C'est ça un premier commentaire. Le deuxième commentaire, s'articule autour de la diplomatie sanitaire face aux épidémies en Afrique. Moi, je pense que le CDC, déjà, il y a pas mal de ressources avec le CDC, parce que j'ai vu un de vos collègues, Benjamin Yuldae, qui s'occupe de la diplomatie. Mais entre pays africains, cette perspective de diplomatie médicale, on doit le renforcer à travers le CDC pour mieux accompagner la gestion des épidémies en termes politiques. C'est là que je voulais avoir comme commentaire. En français, je m'excuse. Mon anglais, c'est un peu moyen, mais je préfère être beaucoup plus compréhensible avec mon français du Sénégal. Merci.
Merci beaucoup, docteur Mustapha. Je pense que c'est des questions de fond, des questions qui ont fait peut-être la différence de la RDC dans la réponse des épidémies à Ebola. Comme on a dit, c'est la 16e épidémie que la RDC a connue. Et le modèle de la RDC qui a été construit, ça a été construit avec des anthropologues. Parce que l'une des grandes difficultés dans le passé, c'était l'acceptation de certaines interventions qui étaient vraiment prouvées sur le plan scientifique, mais qui n'étaient pas acceptables sur le plan social. C'est par exemple ces enterrements avec la façon dont on enterre en plastique, isolé, sans formalité, qui n'étaient pas acceptés. En République démocratique du Congo, au début d'une épidémie, il y a toujours des anthropologues, des socio-anthropologues qui partent pour d'abord expliquer à la population ce que la maladie est, leur expliquer les bien fondés de ces mesures et avoir aussi leur contribution sur la meilleure façon de pouvoir exécuter ces mesures qui soient aussi acceptables pour les communautés dans les contextes où cette épidémie est arrivée. Ça, c'est une bonne pratique qui a été vendue. D'ailleurs, je fais partie de l'équipe qui est allée présenter ça aux Nations Unies il y a peut-être 10 ans pour montrer comment l'anthropologie a été l'un des facteurs de succès dans la réponse de la RDC, contrairement à ce qui s'était passé en Afrique de l'Ouest et la réponse virulente de la population de l'Afrique de l'Ouest. Donc, c'est juste pour confirmer ce que vous dites que c'est quelque chose qui est central parce que certaines mesures sont complètement contraires à la culture africaine et dans le contexte où souvent nous les amenons sur un angle purement médical ou de santé publique qui n'est pas souvent adapté aux réalités sociales de nos communautés. Donc, juste pour dire que c'est vraiment, vous avez une invitation d'Africa CDC. Si votre temps vous le permet, c'est avec beaucoup de plaisir que nous aimerions continuer à échanger pour qu'on ait ces contributions vraiment des aspects anthropologiques dans la réponse aux épidémies. Maintenant, sur le plan diplomatique, donc de la diplomatie sanitaire, comme vous l'avez bien mentionné, il y a toute l'équipe de Benjamin qui travaille là-dessus. Dans les urgences, dans tous les aspects, nous avons toujours le leadership politique qui est impliqué. Toujours politique. Vous avez suivi ce qu'on a fait il y a quelques semaines avec le lancement de la réponse continentale sur le choléra. Vous avez suivi que pour qu'on puisse lancer ça, on a dû d'abord travailler avec l'un des présidents qui a été identifié comme champion de la réponse à l'urgence et qui a mobilisé tous les autres présidents. Il a appelé d'abord une réunion avec au moins 20 pays, dont au moins 10 présidents et vice-présidents ont participé et les autres ont été représentés pour qu'on ait d'abord cette acceptation et cet appui du leadership politique de pays parce qu'on ne peut pas répondre à une urgence sans qu'on ait un appui politique dans la réponse à l'urgence. Et s'il y a peut-être un avantage comparatif qu'Africa CDC a amené dans la gestion des urgences sur le continent, c'est le fait que maintenant, on est capable de combiner le politique, le stratégique et le technique qui travaillent ensemble pour qu'on puisse aller de l'avant. Par exemple, nous travaillons dans un contexte où les ressources financières ont diminué globalement et on pousse un peu plus sur la contribution des États eux-mêmes. Donc, c'est la raison pour laquelle, sur le plan de la diplomatie, on pousse dans cette mobilisation de nos leaders qui peuvent eux aussi jouer de leur influence pour amener les partenaires qui s'ajoutent à eux, et puis eux-mêmes montrant déjà l'exemple par des allocations domestiques qui permettent maintenant aux partenaires de venir ajouter à leur contribution. Je pense que ça, c'est une branche extrêmement importante. À Africa CDC, c'est toute une division. C'est toute une division parce qu'on reconnaît que les succès de tout ce qu'on fait en santé publique dépend beaucoup de notre succès dans la diplomatie aussi. Over to you, Director.
Thank you very much. Let's take the next question. We have Gasho is from the Ethiopian Herald. Gasho, you have the floor. Gasho, if you can hear us. Okay, I think he's not with us. So
Hello?
Yes, we can hear you. Go ahead.
Okay, thank you very much for the opportunity. I have two questions for you, Doctor. Thank you very much. My first question is how much CDC Africa is ready to control if any disease outbreak come to Africa? I think through international funding is now decreasing, so the expansion of disease outbreak is now increasing alarmingly in developing countries, including Africa. What Africa CDC is thinking to fill financial gaps to address the challenges. The other question is shortage of test kits and less quality products are now very critical in addressing disease outbreaks in Africa. So how can CDC Africa can provide technical and material support? Thank you very much.
Thank you. Before Dr. Ngashi comes in, let's take the last one. We have one from Tanaka, a journalist from the Center for Innovation and Technology. What are the latest developments in the SADC area on the progress of the triple elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B? Are there statistics that may show the ranking of these countries? Back to you, Dr. Ngashi.
Okay, thank you very much. Let me start with Gasho's question on how much is Africa CDC ready. As you know, when this financial crisis started, really rose to the challenge and came up with a continental and African strategy to address the public health financing crisis. And then gathered our political leadership, gathered the ministers, and also met with the president just to make sure that we have a response or a strategy that is the result of the co-creation, meaning us as the technical arm, but also being also led and guided by our ministers and our president to come up with a response that is an African response to an African problem. Now, if you look at that strategy, which is the Green Book, which is on the Africa CDC website, if you need, I think, Gasho, you can access it on the Africa CDC website. There are 3+1 pillars of what Africa needs to do. One is that we need to go back to the basics of our commitment to the Abuja Declaration, of getting at least 15% of our budget allocated to health. That is the pillar number one of the African response, is increase domestic resources. Because you cannot claim your sovereignty and your independence if you are not putting your own money into your health and depend on somebody else to pay for your health, and then you are claiming sovereignty. It's a contradiction. And since there was already a commitment at high level of our head of state to the 15% of our national budget into health, that is the good starting point. That is pillar number one. Pillar number two is also understanding that Africa has got its own realities. There's no country that has got enough fiscal space today to be able, through domestic resources alone, really fill the gap and provide enough to cover all the needs of health. There's none. And therefore, we also need to be innovative and think about some innovative financing. That is pillar number 2. Anything that we can do, we have experiences on the continent of health insurances, of sin taxes, of tax levies on airlines, of taxes on mobile communication, on mobile communication. All those new initiatives, we have, in Ghana, for example, there is a VAT tax of about 2% or 2.5% that is contribute to the universal health coverage. I think we have different experiences on the continent that outside the fiscal space of government alone, we can also generate innovative financing as and additional resources that are allocated to health. In addition to that, then the third pillar is also the role of the private sector. You know that health should no more be seen as an expenditure, as a liability. I think health needs to be seen as an investment. And therefore, we are also bringing in, attracting and inviting the private sector to join in so that they can invest in health. If you look at some of the things that are critical for our own sovereignty, and also to your question about dealing with those growing emergencies, one of the things that we need to produce our own medical countermeasures on the continent. We need to produce the vaccines that we need on the continent. We need to produce the tests on the continent. We need to produce the treatment on the continent. That is part of that African manufacturing agenda. Since we don't have all the money that we need to be able to push that agenda, we can also attract the private sector to invest. It's an investment, it's not a grant. They will be getting a return on investment. That's why they will be getting. But us, on the public health side, we are getting the medical countermeasures that we need for the continent to be ready. And then the plus one that I said is that within all that, we need to look at issues of governance. We need to look at issues of efficiency, corruption, and so on to make sure that we can get the best value for the money that we are investing in health. That is how Africa CDC has been leading this continental agenda with the support from our ministers, from our president, to make sure that we have an African solution to an African problem. Now, in addition to that, we have also put in place the African Epidemic Fund that was already approved by our head of state as a mechanism that can allow us to mobilize funding and make it ready for deployment, in case of an emergency, so that, we won't be waiting for the outside partners, to give money for us to start to respond. As soon as something occurs on day 0, we can get our own money from the African Epidemic Fund and transfer it to the country for the country to start responding. Africa CDC has already put also that in place. In addition to that, we have also put in place the rapid responders, so that you understand the thinking about Africa CDC to get the continent ready is to have a system that allows the continent to respond immediately. In the system, you have money, you have the supplies, drugs, vaccines, and supplies, and you have the people. I think those are the things, just to give an example of some of the things that Africa CDC is doing to get this continent ready for the next epidemic or for managing the growing outbreaks. Now, I think the last question is on
HIV.
Yes, HIV and... So the last question was on the developments in SADC on the triple elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B.
Yeah, I think it's a triple elimination of HIV, syphilis, and hepatitis. Yeah, I think you want to respond? Yeah, I think what I know, I don't have all the details, to be honest. I don't know our colleagues from the PHC Center and Maternal and Child Health. I don't see any one of them really that is connected here. I'm told that it is making progress. That is what I'm told. But we would just want to say that, mother-to-child transmission is a priority for improving maternal health, but also newborn health and child health. The elimination of HIV is one area that the SADC region has done more progress than any other region in Africa. When you look at the progress, because of the fact that the HIV response was actually led by the SADC region, when you compare the progress made in SADC region compared to the Eastern Africa, which is the second in terms of progress, and then Central Africa and West Africa that are far behind. I think this triple elimination was kind of the natural progress, building on the experience of progress on the mother-to-child transmission. If you look at Botswana, for example, they have already exceeded 90% coverage of PMTCT in the country. The natural progression is now through integration. How do we then move into multiplex testing, for example, so that as you test for HIV, you are also testing for syphilis, you are also testing for hepatitis, so that based on the diagnosis, we can then channel that mother toward the right management. I think, but I promise that once we get to the right people, we get to the numbers. I don't have all the numbers on top of my head.
Yes, thank you very much. And with that, we have come to the end of the briefing this week. It was a long briefing because we had so many questions to cover. So I'll hand the floor back to you, Dr. Ngashi, for your closing remarks.
Hey, thank you very much, Director. I think, first of all, just to thank all our partners for this continued support. I think that we have had with them. This interest is also our motivation because we feel that we are accountable to you. Just to let you know exactly what progress we are making. As we always say, your questions are also guidance to us so that we can see exactly what are some of the things that are important to you, that are important for the response that Africa CDC and the Continental Incident Management Support Team should be focusing on. Now, it is clear that we are in the context where we are dealing with multiple disease outbreaks at the same time. As we said, we have reported to you on Mpox, we have reported on cholera, we have reported on Ebola. Just to continue, the list doesn't end there. We also have measles that is going on in a number of countries. We have polio, that is going on in a number of countries. I think that is the context that we are operating. And therefore, first of all, it requires better coordination to ensure that with the minimal resources that we can have, we can try to do more for less to really optimize the return on the little investment that we have. It is also from there that you understand that we can't do everything. I think then the whole issue of prioritizing, knowing that what is it that we can really do that will have multiple return on our investment is where we stand right now. And we know that the commitment of all our partners. That is also the reason why this Continental Incident Management Support Team is here with all the experts, the global experts that sit here, over 28 organizations that are bringing just their brains together to make sure that as we move forward, we can be much more integrated. We can really try to prioritize where we get most of the results and also think about efficiency in our work. I think with that, I would like to thank you really for your attention and really hope to see you again next week on the same day at the same time. Thank you very much and goodbye.